disease. So this heart disease is pregnancy is the most one of the most common medical disorders of pregnancy, and its incidence is about 1 to 4% cases in pregnancy. So 1/4 of all the heart diseases in pregnancy are valvular heart diseases, and it is an important cause of maternal mortality. So it can be divided into two, like congenital or acquired. So basically acquired is due to, what is the cause of acquired? That is rheumatic heart disease, and the congenital one that contains the bicuspid valve or mitral valve prolapse, these kind of diseases. So in India, where the rheumatic fever is like it's a common, so it contributes to around 70% of cardiac disorders in pregnancy. So this is what this is all what is the physiology of like worsening of the symptoms in the pregnancy, because pregnancy itself is there's lots of hemodynamic changes during pregnancy. First of all, there is so if any problem, you people can unmute yourself and say if any problems, if my screen is not visible or am I not audible. So expansion, first of all, there is intravascular expansion of the volume, which is a normal physiology during pregnancy. It leads to the increased heart rate and stroke volume, and because of this there is increase in cardiac output. So this is the normal physiology which happens during the pregnancy. But these symptoms, the symptoms of these hemodynamic changes, they aggravate during the heart disease because all patient is already in a decompensated state. So what happens in second trimester, the volume continues and peaks at around 32 weeks. So then during that labor, when a patient is delivering during the second stage, and when patient is getting uterine contraction, that time is very crucial to the patient, and just immediately after the birth or just early postpartum period is very important. So there are three phases where there are high chances of cardiac failure in a heart disease patient, that is at the 32 weeks, during labor, and just immediately after the delivery or just immediate postpartum period. So these are the periods where the patient is on high risk. So same physiology continues in second trimester. There is volume expansion, then there is peripheral vasodilatations and fall in blood pressure. So these are the cardiovascular changes which happen during pregnancy. So you can see in cardiac output for in first trimester it is 5 to 10% increase. Second trimester is at 35 to 45%, and you can see over here early postpartum period it is 60 to 80% just immediately after that, and then rapidly decrease within first hour. During first stage and second stage, this is 30% and 50%. Then heart rate also 3 to 5% in the first trimester. Then you can see during labor, uterine contraction is 50 to 40 to 50%. Same is blood pressure decreased 10%, 5% in the second trimester, and during uterine contraction or labor, it is the systolic BP increased to 25% and diastolic 15%. Then again in the postpartum period, it decreases. Same as plasma volume, it increases 40 to 50% during the second trimester or at the end of second trimester. So what happens during when a patient is in labor, there is around 100 ml of auto transfusion happens during the contractions, right? So if 500 ml of this blood is going to the heart, increasing the load on the heart, and it is the cause of heart failure during labor. So the types of heart disease in pregnancy we see is most commonly is rheumatic heart disease. So rheumatic heart disease is because of inflammation and it leads to the valvular lesions. Then cardiomyopathies, they present in late pregnancy or early period or up to the 6 months after delivery. So most 25% of the affected women, they are hypertensive. Then ischemic heart diseases, the risk factors are chronic hypertension, preeclampsia, diabetes, smoking, obesity, and hyperlipidemias. Then congenital heart disease is prevalence is around 0.8%, and this is one of the most common congenital anomalies seen. Aortic dissection, which is due to systolic hypertension. Then types of valvular lesions which are there because of rheumatic or because of maybe congenital. So there's a mitral stenosis, aortic stenosis, mitral regurgitation, aortic regurgitation, and tricuspid regurgitation. So most commonly the patient we see is of mitral stenosis, and the second one is mitral regurgitation. So mitral stenosis, mild cases are at low risk, but moderate cases there is mortality of 3% and more in the severe cases. Aortic stenosis, the heart failure rate is 10%, and there is also risk of arrhythmias in 3 to 25% patients. Mitral regurgitation, and because mitral regurgitation, the lesions are better tolerated, but severe cases they increase the risk of heart failure and arrhythmias. Similarly, aortic regurgitation also severe cases can be dangerous to the patient, and same is for tricuspid regurgitations. So this is the fetal risk to the mother. There can be intrauterine growth restriction, prematurity, and stillbirth. So it goes on with all of the cases, but then the incidence or the risk is a decrease with the with regurgitant lesions. So how to go about the case of a heart disease? First of all, is very important to diagnose the case, because this many patient, because of physiological dynamic changes, you are not able to pick those cases. So this is very important. Next is investigations, risk assessment, how to assess the risk, which patient is a more risk or which we can follow in the OPD or which we have to admit. Then how to give the antenatal care to the patient, various drugs which are used, how to monitor, then how to make the plan of delivery, labor management, and the postpartum care. The antenatal diagnosis should be made whenever patient is coming to you at the her first antenatal visits. So of course, as you take the cases, so you have to write down the complaints, take the proper history, and along with the past medical history, family history. So then, especially if you suspect any case of heart disease, so you especially ask about the breathlessness, and that too you ask on exertion, where the breathless exertion or the rest. Then orthopnea, fatigue, palpitations, chest pain, cyanotic spells, fever, past thromboembolic events and or their treatment, and past history of surgeries, any kind of interventions, or deep vein thrombosis. So these histories you have to take. So then you have to, according to your history, you have to categorize your patient. If patient has to be given the routine care, if there should be any caution, or we should, there is high risk, that is a red one. So if she is saying shortness of breath, if there is no complaints, then it's routine care you have to give. If she is saying yes, then you have to assess the patient. Same is with chest pain. Uh, it can be reflex associated, which resolves on the treatment. So it can be atypical chest pain or at rest or with minimal exertion. Palpitations, if that is for few seconds, self-limiting, no harm. You can follow up in routine basis. If that is brief self-limiting episodes with no lightheadedness or syncopal attack, then you have to be cautious. And if it is associated with near syncope, you have to be see or assess the patient. Then syncope also, if long standing or due to dehydration, you have to follow. If that is vasovagal, that comes in the caution category. And if it is exertional or unprovoked, then you have to see, you have to investigate. Similarly, in the fatigue, mild is okay, fine, it can happen in the pregnancy, mild to moderate or extreme, you have to be cautious. Similarly, you have to see the heart rate, systolic blood pressure, respiratory rate, oxygen saturation, and other physical signs like JVP or the heart sounds, lungs, and edema, pedal edema, or for the signs of failure. So this is the WHO classification or risk classification of the woman according to the signs and symptoms. So they have categorized into the 4 classes. So basically class 1 is the mild cases where you can follow them on OPD basis and give a routine care. Second and third classes is like we have to be very cautious about these patients. Then the fourth category is where pregnancy is contraindicated. So these are the cases like patient is like having pulmonary arterial hypertension, severe systemic vascular dysfunction, if ejection fraction is less than 30%, and previous peripartum cardiomyopathies is there, any residual left ventricular dysfunction is there, severe mitral stenosis, severe asymptomatic aortic stenosis, uh, systemic right ventricle with moderate to severely decreased ventricular functions, aortic dilatation of 45 mm, more than 45 mm, England loss, and severe corruption of aorta. These are some where the pregnancy is contraindicated. So if patient is coming to you before pregnancy for counseling, you have to say in these cases that pregnancy is contraindicated, you should ask to use contraception or any other like permanent sterilization to uh, avoid the pregnancy. So this class 1 is uncomplicated or mild or small pulmonary stenosis, PDA, MVP. So these needs routine care. Rest of the classes, class 2 and class 3, have to be individualized, a patient in worsening or stable. So you have to follow these patients. So on examination, as told you, vitals you will see for pulse rate, volume, regularity, rhythm, blood pressure, neck, GVP, then heart sounds. So what happens there is you have to differentiate between physiological changes and the because of heart disease. So first heart sound, that is because of the hyperdynamic circulation during pregnancy, because of anemia and all. There can be increase in intensity of S1. So S4 is occasionally heard and S3 you can occasionally heard. Then if there are murmurs, so physiological murmur is an innocent murmur which is because of the hyperdynamic circulation. These murmurs are usually mid-systolic and soft, heard best on the lower sternal border and over the pulmonic area. Rest of the murmur are the pathological murmurs. Yes, you have studied in medicine, like for mitral stenosis is diastolic murmur at the apex. Uh, then mitral regurgitation, pensystolic murmur, or aortic stenosis, systolic ejection murmur. Then you have to see for the lungs any adventitious sounds or extremities for edema and the varicosity. Now the frontal examination is the same as you do in all the patients. Frontal height, lie, then you have to see the fetal heart rate, like and symphysiofrontal height as you see in all patients. PV to be done only in the labor or if patient complains of leaking or abdominal pain. Then to categorize the patient, if she needs the OPD care or the hospital care, this classification is made. That is New York Heart Association classification class. So patient is categorized into class 1, class 2, class 3, and class 4. So this is the classification you have to do each and every patient on and each visit of the patient. Class 1. So class 1 is when the patient on ordinary physical activity doesn't cause any fatigue, palpitation, or dyspnea or angina. Class 2 is when patient is symptomatic on ordinary physical activities. Then class 3 is when the symptoms are less than the ordinary physical activities. And class 4 is on rest. Symptoms are on rest. So how you take the history in these patients, you will ask the routine household work if she can do or she cannot. So if you will ask the if she is able to do her routine household work activities, if she says no, she's not able to do it, that means class 3. And if she's like if she says if she becomes symptoms, she develops symptoms only mild exertion, so that is class 3, less than the ordinary physical activity. If she is developing symptoms, that is class 3. Class 4 is when she is having the symptoms at rest. So these are the investigation you will advise, all routine investigations of the pregnancy you advise. Then of course to rule out the diabetes, GCT or HbA1c. First and second trimester screening for congenital disease, congenital fetal malformations, USG level 2, ECG, echocardiography, D-dimer, and fetal echo. So these are the routine investigations when you prescribe heart disease patients. So what are the principles of antenatal care? So first of all is in any heart disease patient, according to her severity, she should be not on the severity, she should be registered at a tertiary healthcare center because she may need ICU beds or any kind of intervention anytime. So that these patients should be registered at a tertiary healthcare center where all the HDU, ICU, all kind of investigations, multidisciplinary team is available. So a second line is managed by the multidisciplinary team. That means the cardiologist, the anesthesiologist, and the gynecologist, all three, they will work simultaneously. They have to see the patient and assess the patient accordingly. Then there should be a comprehensive plan of antenatal care, intrapartum care, and postpartum period prior to the early in the pregnancy. So you have to counsel the patient or the attendant what will be the plan. If she worsens during any part of the pregnancy, she will be hospitalized, she will be worked up and all. So fetal echo is done if there is any patient is having congenital heart disease. So in those cases, because there are chances of heart disease in the fetus, so fetal echo to be done. That is done in 18 to 22 weeks of gestation. Then because these patients there is a insufficiency, placental insufficiency to the fetus, so fetal growth assessment is very important. So by clinical or USG method, you have to track on the fetal growth. Then low dose aspirin prophylaxis you can give in the high risk cases where you suspect the patient can develop preeclampsia, like patient she is having hypertension, or she is having other high risk factors like EPLA, antiphospholipid antibody syndrome is there, chronic hypertension is there, and she is developing symptoms. So you have to start with aspirin prophylaxis. This is very important, anticoagulation switchover. This you need when patient is already gone through the intervention, like she's have a biostatic or any mechanical valve in situ. So, and she's obviously she remains on warfarin. So as soon as you come to know, or a patient comes to you after in early pregnancies, like 4 weeks, you have to secure the anticoagulation, the method of anticoagulation from warfarin to low molecular weight heparin, because warfarin it causes embryopathy. So you have to switch over. You just stop the warfarin and switch over the patient to low molecular weight heparin. Then in these cases, you have to admit the patient and see the coagulation profile and all. So she will need 2 to 3 days of admission to stop. So warfarin she takes orally, low molecular weight heparin you have to give subcutaneous injections daily. So after workup you can discharge on low molecular weight heparin, and that will continue till her pregnancy till 36 weeks. And whenever there is chances that she will deliver, then low molecular weight heparin should be stopped 12 hours before she expected to go in labor. Then NYHA grading of the new symptoms. Any time of pregnancy, suppose initially in pregnancy she was comfortable, and during the course she's developing some kind of symptoms, so you have to grade her in. Then endocarditis prophylaxis before any procedures or selected case. Suppose she may be already taking this prophylaxis before the pregnancy, then she have to continue with the prophylaxis. If she is not taking, you have to give. Then if patient is severe and she needs some intervention, surgical intervention, then the second trimester is the best option to do the intervention. So balloon valvotomy can be done after 28 weeks if there is worsening of symptoms. And there should be restriction of physical activity and hospitalization if there is any symptoms. These are the drugs which are used in the cardiac patients. Hypertension, as you know, labetalol, nifedipine, and methyldopa. So most commonly used is labetalol. So you same drug you can use in pregnancy. Then heart failure or pulmonary edema, then you have to use beta blockers, digoxin, and diuretics. So the furosemide is most commonly used in these cases. To decrease the preload, diuretics and venodilators. To decrease afterload is hydralazine, which is arterial dilator. Then anticoagulants for mechanical valves. So as I told you, warfarin, because warfarin is an embryopathic drug, so you have to stop the warfarin and switch over to the low molecular weight heparin. For arrhythmias, adenosine, beta blockers, and verapamil, and if it is not, then electric defibrillators are used. And in also atrial fibrillation, you can use beta blockers, verapamil, and digoxin. So how to do fetal monitoring? It's obviously you have to see for the fetal growth. Clinically you can do by symphysis fundal height and level 2 ESG to be done in each and every patient. Then uterine artery Doppler in the second trimester 22 weeks to predict or to see if there is possibility of fetal growth restriction. So if that is abnormal, you have to follow in 2 weeks. Daily fetal movement count you will ask the patient to do, then ultrasound Doppler follow-up if growth restriction is there, NSTs and biophysical profile. These are the methods you can use after 28 to 30 weeks. Then plan of delivery, it should be discussed around when patient is in second trimester. It's not like that you have to follow and you just keep on following the patient. You have to make a plan of management of delivery. Suppose patient is primary, you can make a plan that we will deliver the patient vaginally if she is previous to sections or any kind of indication which you know that she will land in the cesarean section. Then you have to plan it in the at around 30 weeks. So in that plan management, you will discuss the case with the patient and the relatives, and you explain all the um, all the antenatal care, what you will give and what you will when you will admit or admit the patient for the delivery of if there is some symptoms or there is worsening, we have to admit the patient. So all the patient of heart disease, they are followed till 40 weeks if there are no complications. So there is no indication, if there is no indication of induction of labor, you can safely follow according to the symptoms. If she is comfortable, she can be, the pregnancy can be led till 40 weeks. Then counseling and consent taking before delivery. Then hospitalization. In some cases, you need hospitalization for safe confinement according to the severity. Suppose your patient is getting worsen at 30 to 32 weeks because that is a big time of hemodilational changes. So you can hospitalize this patient for safe confinement. She will remain in the hospital. You will monitor the patient and she will deliver whenever she goes in labor. Always vaginal delivery is preferred for the cesarean section, but until unless there is a indication for like fetal distress is there, CPD is there, good sized baby, or patient is worsening, patient is going into pulmonary edema and any other like indications of cesarean section, then in selected cases you go for cesarean section. Then you have to maintain the records, the antenatal records, the labor records, and the if patient is hospitalized, you should maintain all the records. Anticoagulation should be stopped 12 to 24 hours before planned induction or labor onset of the labor. Coagulation profile, blood products to be arranged if that is any derangement in the coagulation profile, or blood to be arranged if patient is anemic. There also a multidisciplinary team must be involved in the plan. Then principles of labor management. These are the principles which should be followed in whenever patient is going into the any heart disease patient is going into the because patient can worsen anytime. So this is the standard principles you have to follow in each and every patient, not the patient to be categorized. So every patient there should be general principles of intrapartum we follow. So first thing is to minimize the cardiovascular stress. To minimize these stress, these are some, I'm going to tell you some management, some what you have to do. Pain management, because pain, what the pain do is when there's a pain, there's increase in heart rate, increase in stroke volume and cardiac output along with the uterine contraction. So it is aggravating the heart disease or the symptoms. So pain management is important. Meticulous use of IV fluids because there's chances of fluid overload in these patients. So patient should be keep on oral fluids until unless she's going in shock and there's chances of hypotension, and you give the IV fluids only in those cases. Otherwise, she will put on the oral fluids. For pain management, you can use an active stage of labor, epidural anesthesia can be used, and assisted vaginal delivery to cut short the second stage of labor. Cesarean section is usually necessary only for the obstetric indications. There should be As I told you, tertiary, all patients should be admitted into the tertiary centers, healthcare centers, where there is high dependency unit, intensive care units. So you can shift the patient anytime if she is worsening. So this is the intrapartum care you have to give. Adequate hydration via oral intake. Then secure both side IV lines. Right? Because you need any kind of injections or IV fluids during the procedure. Then meticulous use of IV fluids. Propped up position should be there. Patient should be kept propped up. Continuous vital or saturation monitoring by monitors, which are there in the labor room or the HDU or ICU. That should be on all the time. Then if she requires, slow oxytocin can be given, like whatever be the requirement, it should be slow, because oxytocin can also precipitate the overload. So slow IV oxytocin has to be given, good analgesia or epidural to be given in the active labor, and restricted PV examination should, because the more the PV examination, the more chances of going the infection. So PV should be done only when it is indicated, not that routinely 4-hourly or 6-hourly should not be done. It should be done only if patient complains of leaking, to see if there is any cord prolapse or what, any meconium. And during the, when patient is bearing down, when patient complains bleeding or anything, then you have to the PV. For the assessment, you should avoid the PV examination. Then second stage of labor should be cut short by applying forceps or vent tubes if it is getting prolonged, not otherwise. So to cut short it, why we need to cut short the second stage is because in second stage there is uterine contraction. Because of this, there is auto transfusion of, as I told you previously, there is auto transfusion of blood, and there are chances of the going into the failure. So that's why you need to cut short the second stage. Then after the delivery, prophylactic injection furosemide 20 mg IV to be given after checking the blood pressure. So if a blood pressure is more than systolic 100 more, and is more than diastolic more than 70, you give. Otherwise, you will not give. Then oxygen inhalation according to the saturation. If she needs, you have to give the oxygen, or in case of fetal distress, a patient is symptoms, respiratory rate is rising, you have to give the oxygen. So here, what you mean by meticulous use of IV fluids? Generally, during the labor in antenatal patient, we used to give 100 to 125 ml of uh, per hour of fluids, but in the heart disease, you have to restrict this till 75 ml per hour. So that is the meticulous use. If you are using the IV fluids, that has to be 70 to 75 ml per hour, and not more than that until and unless there is that is indicated. There's hypertension or any other complication, you have to give the IV fluids. Otherwise, 75 is enough for the patient. So what can be the cesarean section indication in the heart apart from the obstetric indication? The other indication where you can need a cesarean section is when patient is going in the pulmonary edema. So how to detect that during the labor, how to detect the patient is going into pulmonary edema is when you are monitoring the patient, there is increase in heart rate, saturation is falling, and the respiratory is increasing. So these are the, and there is creps, basal creps is present over the chest. You have to see all the things, and if you suspect any the chances of heart failure, you have to give, what you have to give, diuretics, furosemide you will give, and you have to call the anesthesia team, cardiologist team to assess the patient, and accordingly you have to manage. So this is the one indication where we need immediate cesarean section just to prevent the heart, that process of heart failure. That is, and other thing, other indication is when this patient is uh, already she has developed pulmonary hypertension, then you sometimes you need to go for direct cesarean section in those cases. How the one thing which is very important is in this is how to give the prophylaxis, carditis, endocarditis prophylaxis, because many of patients they are coming unbooked, they are not taking any treatment, and they are suffering from rheumatic heart disease. So in those cases, benzathine penicillin is which is most commonly used for the prophylaxis. It is given at the interval of 4 weeks. So it is 1.2 million units which has to be given. This is an injectable form which has to be given over the period of 4 weeks. So each for every 28 days she will receive the injection. So this is how you give the prophylaxis for endocarditis. And additionally, you have to add the antibiotics before any kind of procedure. Or there is new onset fever or any symptoms, then you have to give the other antibiotics. So this is the long-term prophylaxis for the benzathine penicillin is a long-term. So she can be given, usually what happens during any kind of, if she has a history of carditis or she's having residual valvular changes, valvular diseases, so she has to take for 10 years, that, or 10 years or 40 years, which is the maximum. In cases of carditis is there but there is no valvular changes, then again it has to be given for 10 years, but the, or 10 years or 21 years, whichever be the longer. And if she doesn't have any carditis, if she has doesn't have carditis and only valvular changes are there, then you have to give it for 5 years. So this is how it is available in injection form and tablet form both. Then postpartum care, the close monitoring after the 24 hours of delivery, because this is the most crucial. Uh, I told you there are 3 points where you need to monitor. That is at the 32 weeks, during the labor, and immediately postpartum, because there is a reversing of all the changes. The hormones are going down, the whatever changes has occurred during pregnancy, they are reversing. So there is lost lot of hemodynamic instability during that period. So for 24 hours, it's not like suppose patient has delivery, you have to keep that patient in the intensive care unit or the HDU and to monitor for 24 hours after delivery. Then the risk of heart failure not is not uh, maybe up to 6 days after delivery. So patient should be kept admitted for 5 to 6 days, and she should be monitored and should be discharged after that. Then in postpartum care, apart from this, you have to give routine care like breastfeeding or antibiotics and ambulation, whatever the patient usually you prescribe a patient with normal delivery, you have to prescribe that. Then contraception is a very important part because sometimes you need that or the patient need that she should not conceive, so that should be done before you discharge the patient. Either you put the copper T during the labor or after cesarean section, that is post placental contraception. Or if she's not willing for post placental, then you ask the patient to follow in the at the 6 weeks. So the combined hormonal, that is not preferable in these cases, but IUCDs and progesterone hormones you can use safely. Progesterone hormones, only progesterone hormones you can start after the delivery, and if she is not willing, then you can ask the patient to come at the 6 weeks or 6 months for the further planning. Any questions you people want to ask? Do not log out because I'm taking your attention. Just hold on for a few minutes. So we are concluding the session. Any question?